So we have the control modes, which is CMV. Previously, we used to call it continuous mandatory ventilation. The CMV word is also used as conventional mechanical ventilation. So if anyone says the word CMV now, we more mean conventional ventilation than against high frequency, not the continuous mandatory ventilation. So the mandatory ventilation has gone out of vogue totally. We have intermittent mandatory ventilation. In the continuous mandatory ventilation, there was no possibility for the baby to breathe. So you can forget that, that's obsolete now. It's any mode of ventilation now which is invasive will be IMV based, and IMV means intermittent mandatory ventilation, which means in between there is a bias flow and the baby can take the breaths in between. And we have the synchronized modes, SIMV, SIPPV. So below that, access control, PTV, PSV, they're all modifications. And PSV, as you know, is patient support ventilation. Mostly we use it along with SAMV. PSV alone can be used as well, but in my use, I prefer to use SAMV with PS. So we mentioned this already, that in paralyzed patients, it's a word CMV, but if you use IMV, it's the same in paralyzed patients. The synchronization won't work in a paralyzed baby, but no harm if it's not wrong if you keep. So it's not wrong if you keep SAMV in a paralyzed baby, because essentially it will work like IMV. But when the baby starts waking up, you don't need to remember to change the mode. So synchronization will work if there is baby's efforts. If it's not there, it will work as a backup mode. The backup settings have to be higher if the baby is sedated or paralyzed. So synchronization is a very important concept to understand, and in the demonstration session, the clinical application specialist will show you about how their flow sensor works and how the synchronization trigger options are there. So synchronization basically means we are timing the ventilator breath delivery to the patient effort, and that's the most crucial advances in ventilation in the last 25 years or so. Because with synchronization, we are able to confidently, in the past 15 years, most of the NICUs moved away from routine sedation. When I was training, we used to give morphine for any ventilated baby as a routine. But now we don't prepare morphine even for most of these babies. That's only possible because we have synchronization. And even though the research evidence for synchronization, of course, we have evidence for volume guarantee, but for synchronization itself, the research evidence is not strong because it's multi-parameter that affects. So it shows that it helps a baby, the comfort level is better, but the outcome like BPD is not shown to be beneficial. But that's difficult to assess in a research setting. Multiple factors impact on it. So we obviously not using sedation itself is enough reason to synchronize. And lots of changes. It's much quicker microprocessor technology, the speed at which the flow sensor is picking up and the sensitivity is very good. And of course, the modern modes like volume guarantee depends on picking up information as well. So synchronization needs the flow sensor, and these measurements and then modes also come through that. So as I mentioned, there is definite improvement in clinical measures of synchrony and reduced need for sedation, but no significant impact demonstrated on the long-term outcomes. The poor synchronization causes the baby to fight with the ventilator. There is increased work of breathing as a result. There is also abnormally high intrathoracic and intrapulmonary pressure surges. So this may affect the brain of the preterm baby, for example. The reduced venous return from this fighting may also impact the risk of IVH, and barotrauma leading to volute trauma and chronic lung disease risk going up. And because there is asynchrony, the phasic breathing may be different. So you may not train the baby's muscles adequately to extubate. If the baby is not sedated and they are triggering the breaths and it's timing with them, the breath phase is in sync. So when they extubate, they are not confused. So we have the trigger mechanism, which is what causes the breath to begin. Then we have the limit variable, which is the one that regulates the gas flow during the breath, and the cycle mechanism, which causes the breath to end. So limit variable, mostly it's pressure. In volume guarantee, it's the tidal volume that's achieved, and it takes the pressure that is needed for that. And the trigger mechanism, most of us use the flow sensor and the flow trigger for that. And the proximal trigger is not the ideal option. And we have the cycle mechanism in mostly it's inspiratory time in the regular ventilation, but in pressure support ventilation, we have the flow itself. When it drops to say 20% or 15%, it cuts off at that level. So in inspiratory trigger mechanism, time cycling can be there where there is no patient interaction. The pressure transducer is usually at the ventilator end, and the proximal end, which is the flow sensor, the pneumotachograph or the hot air anemometer. So during the next session, he will explain to you about the flow sensor as well. And the ventilator senses a drop in the flow with the patient effort, and that flow difference is because of the heater where the electric activity is changed and it picks up the flow difference. We also have chest impedance leads and Graysby pressure capsule, not commonly used. We used to have the infant flow what is it? Infant star ventilator, but it's not used much anymore. And recent ventilators are coming up with these Graysby capsules for synchronizing for the non-invasive modes. So for example, I think the Stefano or some ventilator is coming with that. So that's coming again for non-invasive. And I think the MAC-K is coming with proximal flow sensor trigger for the NAPPV. So triggered NAPPV option is coming up as well for the, you don't have the hot air anemometer, but you have the pressure sensor for the ventilator. So for synchronized, in addition to NAVA, for non-invasive, we are also getting other options now for NAPPV, which is synchronized, but most of us use non-synchronized NAPPV. So the problems can happen with the trigger mechanism. The trigger threshold may be too high. So always when you set the ventilator, you look at the size of the baby and set the trigger threshold according to the size. So mostly it's set, we will discuss both the ventilators, trigger setting, SLE and Drager in the next setup. Antiphasic trigger happens with abdominal sensor placing, where if you have placed it too low, the expiratory phase may be triggering the inspiration. So it goes out of sync. That doesn't happen with the flow sensor triggered ventilation. And auto triggering is where it's very sensitive and it picks up non-respiratory stimuli. So it can be water in the circuit, something vibrating, which is causing the stimulus. So obviously, if you're on assist control mode, for example, you're going to trigger far more breaths. And it's something to be careful if you're using a ventilator setting where every breath is supported. So then you're going to cause more damage, more over distension and barotrauma. So the delayed responsive time, I mean, the effective response time is a combination of the trigger delay and the system delay. I told you that the system delay has become much lower these days with advanced ventilators. So previously we used to talk of 50 to 100 milliseconds. Now it's much shorter than that. And 5 to 100 milliseconds can be there. Even 5 milliseconds delay can be there. The system delay, again, it's dropped well below the 25 milliseconds I've mentioned there. So the systems are getting more sophisticated. They're quicker in acting, but you need a good system. If you buy a cheaper ventilator, you need to look at these aspects. So you may be saving on cost, but what is on the tin may not be reflected. So it may say it will do volume guarantee or it will do, but the synchronization won't work. The measurement lag is more. So the delivery, that's why most of us prefer a reliable ventilator. I mean, this cheaper ventilator may show the same function. Recently, we trialed a video laryngoscope, which is a cheaper one, but even the way the camera shows is right at the end of it. There is no zooming out. So that makes it difficult to intubate. So you're not getting a real picture. So a cheaper version may not really have the proper input you need. It may have all the functions, but it may not work as it should because of the delay, and the software speed is very important. So we have again flow trigger, pressure trigger, and the NAVA. So again, I have covered this, so I'm not repeating it. The limit variable, the pressure limit is a common variable in the predominantly used modalities. The volume limited ventilation is not used in newborns because of the ET tube leak and things. Some units in UK, Middlesbrough, and they used volume limited ventilation, but mostly we are now switching to volume guarantee, which is pressure limited, but with the volume guarantee as a limit variable as well. And time is a limit, I mean, cycle mechanism in all the modes except the